Okay, guys, we're going to start. Thank you all for coming. Good afternoon. My name is Dr. Hans Stewesen. I'm the Ingalls Brown Professor of Biomedical Sciences and the Chair of the Department of Biomedical Sciences in the College of Medicine. For those of you who are M1s, about 80% of the faculty in the M1 year is in my department, our faculty in my department. So it's my distinct pleasure today to welcome you to the annual Watanakunakorn Lecture. And before introducing Dr. Bloch, I would like to take a moment to share the story of how this lecture series came to be in existence. And I want to express specifically the gratitude we have for the donors who were involved with that, the Watanakunakorn family. Dr. Chatrchai Watanakunakorn was a beloved professor of internal medicine at this school, and he was the director of infectious disease at St. Elizabeth Health Center in Youngstown until he passed in 2001. In 2004, the Watanakunakorn family made a remarkable gift in his honor, his passion for medicine and his profound contributions to medical education in Ohio and specifically at this school. On March 5 of that year, 2004, the family presented the NeoMed Foundation with its largest charitable gift that it had gotten at that time, $3 million. And that generous gift was used to rename the F building, which is the tall research building in the back, for Dr. Watanakunakorn and his wife, Eleanor. It established a endowed chairship, which is held by Dr. Ping Zhang, who's sitting there. And it also created scholarship endowments for students at the College of Medicine. In 2015, Eleanor Watanakunakorn, and you see here above me in the picture in the middle, she made two additional transformative gifts to NeoMed. She donated funds for this particular auditorium, and that's why it has her name. And she also established an endowment to fund this annual lecture series, enabling us to bring esteemed speakers like Dr. Bloch from all over the nation to us and talk to us about issues in infectious disease. To date, Eleanor Watanakunakorn has donated more than $6 million to the NeoMed Foundation. So it's my distinct pleasure to share that Eleanor Watanakunakorn is with us virtually today from a home in California. So please join me in recognizing her. Thank you. Then let's introduce our speaker, Dr. Karen C. Bloch. M.P.H, M.D. is a highly respected infectious disease specialist at Vanderbilt University Medical Center, where she combines her passion for patient care with an exceptional depth of knowledge in that field. She's a four-time recipient of the Vanderbilt William Schaffner's Teaching Award in infectious disease, and she is known for her expertise in managing complex infectious disease cases and her dedication to the patient experience. She has played a pivotal role in pioneering the first remdesivir infusion clinic in Middle Tennessee during the COVID-19 pandemic, and she continues to be a leader in infectious disease education and research. As a recognized expert on encephalitis, meningitis, and tick-borne infections, she has authored a number of publications that served in key roles with the Infectious Disease Society of America, and her tireless contributions were recently honored with the 2023 Watanakunakorn Award from the IDSA. So please join me in welcoming Dr. Bloch.
Thank you so much for that nice introduction, and it's an honor to be here today to give the Watanakunakorn Lecture. The title of my talk is Tick, Tick, Boom, the Explosion of Tick-Borne Infections in the U.S. You've heard a lot about Dr. Watanakorn, and I've spoken to a number of folks who actually worked with him and knew him. And what strikes me about him is his incredible passion and advocacy for infectious diseases. Those who know him also mention he was an incredibly deep thinker with a huge intellectual curiosity. And I think that's borne out when I did a literature search on PubMed looking at his areas of expertise. I was struck by the fact that he had 196 publications. Many of these focused on endocarditis, where he was an internationally recognized expert. But he also served in a role as the head of infection prevention, and so was also quite prolific on publications in the prevention of infections in hospitalized patients. But I knew if I searched hard enough through these 196 publications, I'd find it, and indeed, he had published on tick-borne infections. So my talk today is going to build on Dr. Watanakunakorn's paper and talk about what's happened in the interim with the explosion of new data on tick-borne infections. I have no financial disclosures for this talk, but there are a couple things I wanted to say at the onset. The first is due to time constraints. This will be primarily concentrated on US infectious diseases caused by ticks. My focus is going to be on clinical and epidemiologic manifestations. So I'll give sort of short shrift to diagnostics and therapeutics, but those can be found in any online resource. And finally, I'll say that tick-borne diseases really are the quintessential infectious disease. They marry the interaction between host and reservoir and vector. It's imperative to take a very complete exposure history to determine a differential diagnosis that includes tick-borne diseases. It's a real collaborative work between the clinician, the lab, and the public health infrastructure. And so if you enjoy this talk, consider joining the ID interest group and consider a career in infectious diseases, and I promise you will never be bored. So I've divided this talk into 3 sections. The first is on increases in common tick-borne infections. I think this slide really encapsulates the explosion of tick-borne diseases over the last couple decades. Between 2004 and 2017, there was a 263% increase in reported tick-borne diseases. And I will mention that most of the diseases I'm going to talk on in this first section are reportable to CDC. So that's a pretty dramatic rise. It's important with tick-borne diseases, though, to understand that these are not uniformly distributed throughout the United States. So obviously, the specific tick may spread different diseases. And so you can see that on this map. Each of these colored dots represents a different tick-borne disease. And if you look down south where I'm from, you can see a different distribution of colors than you might see in Ohio. So there is a lot of diversity by geography. But this is a little bit of a Jackson Pollock modern art interpretation of tick-borne diseases. And so I think that this next graph is more helpful in terms of determining burden of disease. So there are 2 striking things about this graph. The first is how important Lyme disease is. It accounts for somewhere between 70 and 80% of all tick-borne disease in the United States. And I think the second thing to notice is this dip in cases between 2020 and 2021. And of course, that was during the height of the COVID pandemic. Public health priorities were elsewhere, and so there was almost certainly underreporting. So you'll see that throughout the talk that those 2 years, I think the data is a little bit questionable. So I'd like to start by talking about Lyme disease, which is the most common vector-borne disease in the United States. It's caused east of the Mississippi by Ixodes scapularis, or the black-legged tick. West of the Mississippi, it's caused by the western deer tick, or Ixodes pacificus. I think it's really reassuring to patients to know that you need 36 hours of attachment for the bacterium, Borrelia burgdorferi, to be transmitted. So if you get a call from a panicked family member, as I often do, it's something that if they've removed the tick quickly, then the risk is negligible. Most cases are transmitted by this nymphal form. You can see how small that is. It's about the size of the E on the dime. And because it is so small, less than 50% of patients recall a discrete tick bite. But I think that this visual may be a little bit more impactful. This was a tweet put out by a staff member at CDC Fort Collins, which is the vector-borne disease branch. And this staff member was making lemon poppy seed muffins. And she realized that these poppy seeds really resembled these nymph ticks. And so she mixed 5 nymphs into the dough and baked them up and challenged the viewer to distinguish what's a poppy seed and what's a tick. So my take-home message from this is, yes, the ticks are quite small, and I don't think I'll be eating lemon poppy seed muffins very much. This is the graphic that shows the number of cases reported to this CDC, and these different colors represent changes in case definition. So it's a little difficult to compare the full extent of burden of disease based on this change in case definitions. But if you just look at the teal bars from 2008 to 2021, you can see there's somewhere between 30 to 45,000 cases per year, which is a pretty significant burden of disease. But it turns out that's massively underrepresenting the true burden of disease. CDC staff members put out a publication about a decade ago where they looked at insurance claims and outpatient encounters and found that the number is probably 10 times higher, somewhere between 300,000 and 400,000 per year. And so this is a huge public health burden, but it's also a huge financial burden. And just to give you an idea of that, just for testing for 1 year, not for treatment, not for management, not for disability caused by Lyme disease, 2.4 million samples at a cost of almost $500 million. Looking at these maps, you can see that there's been a spread in terms of the distribution of Lyme disease in the United States. In 2001, most cases were in the eastern seaboard, in coastal areas, and then a smattering of cases in the Great Lakes state. And less than 20 years later, you can see a massive redistribution where almost the entire Northeast is involved, the Mid-Atlantic is involved, and there's that tongue. I wish I had a pointer, but you can see that tongue reaching into Ohio as well. So we're seeing a spread of disease into areas where it previously was not terribly prevalent. This is data from the Ohio Department of Health that again shows this trend, rising cases. I don't know what to make of 2023. It may have been a banner year and it may just represent the change in the case definition. But if you look from 2014 to 2022, cases have really more than doubled. And where the tick goes, the disease follows. So not surprisingly, we see a increase in the number of ticks found in various regions that are now highly endemic for Lyme disease. The map from 1996, the yellow areas are areas where theoretically the Ixodes tick could thrive, and the red areas are where 6 or more ticks have been identified. And then by 2020, we see a whole lot more red. So how do we explain this explosion in Ixodes ticks in this region? And I think there are a couple of different theories, and I'll put those forward now. The first has to do with climate change. It directly can affect ticks. There are certain geographic regions that perhaps were not terribly hospitable previously that now, due to changes in temperature, are much more able to support tick growth and tick living in those areas. Secondarily, there can be changes in habitat and hosts that are affected by warming, and this may again promote feeding patterns for ticks. And then finally, with warmer weather, people are outdoors more and they're going to have more encounters with ticks. So all those may be playing a role. There are also changes in land use that are likely contributing. This is a study from Scandinavia, and it focused on urban green spaces, so sort of pocket parks or more areas in high population density regions. They did surveillance for ticks, and not only did they find a lot of ticks in these urban parks, a lot of these ticks were infected with diseases that can impact humans. A second study looked at behavioral variables of people who visited these parks, and they found that folks really weren't very knowledgeable or proactive about taking protection. So 75% of individuals who are going into these urban green spaces said yes, they could recognize a tick if it was on them, but only 40% actively avoided tick habitat, 40% did regular checks, only a third were vaccinated against tick-borne encephalitis, which is a common disease in that region, and then only a quarter used repellent or protective clothing. So if we acknowledge that the rates of Lyme disease are going up, it's important to recognize the clinical manifestations. And this graphic from CDC, I think, does a nice job of breaking down, presenting clinical findings. I'm going to start by talking about the skin lesion associated with Lyme disease, erythema migrans. This accounts for 70% of cases at time of diagnosis. So the erythema migrans rash usually occurs within 2 weeks after its tick attachment, and it occurs at the site where the tick is attached. It's expansile, and the term migrans refers to that. It gets quite big in some cases. And the classic appearance is shown here. It's a bullseye or target lesion. So it's got that central erythema, a ring of clearing, and then a dark red ring around it. These are typically painless. They don't itch. And there's only associated symptoms in about a quarter of cases. And usually those are fairly mild, low-grade fever, myalgias, arthralgias. Up to 80% of cases will have an identified erythema migrans skin eruption. The remainder of cases may be due to darker pigmented individuals or rash in areas that might be difficult to see, like the scalp. So the challenge is that this typical EM rash is actually atypical. And this is a study that was done of 95 patients, all of whom eventually were proven to have Lyme disease and who presented initially with skin findings. Only 9% had that bullseye appearance, and instead what was more typical was confluent erythema, a red spot with red around it, but none of that central clearing, a punctum, or an ulcerated lesion. So again, keeping a broad differential is important. Acknowledging the diversity of presentation, CDC put out this infographic, and again, you can just see the many different ways that erythema migrans lesions can appear. So the earliest manifestation of Lyme disease is the erythema migrans rash, but it can also recur at the time of dissemination. And unlike the initial rash, which occurs at the site where the tick was attached, in disseminated disease, these can be multiple lesions at many sites. Dissemination usually occurs within 10 weeks after the bite. And at this point, patients usually are quite symptomatic with fevers and more of a flu-like syndrome. So while EM can look like many things can also look like EM. So I think it's important to recognize that a number of different syndromes can mimic erythema migrans. Tick bites themselves can cause red areas. There are a number of lesions shown here that are dermatologic that cause a ring-like appearance. And then I don't have time to go into it, but southern tick-associated rash illness or starry can give an erythema migrans-like appearance. So it would make sense to say, okay, if so many things look like erythema migrans, there should be a lab test that could differentiate. And unfortunately, this isn't necessarily the case. This is data from the study that I mentioned earlier, looking at patients who presented with a skin lesion. And what these investigators found when they did serologic testing is that only 27% of cases were seropositive within the first week after presentation. So really, really insensitive earlier on. By 2 weeks, that went up to 41%, but it's really only after 2 weeks that we got to see the majority of patients develop antibodies. And of course, time's a wasting if you're waiting for those antibodies to turn positive, and that gives opportunities for the disease to disseminate. So the guidelines recommend using the clinical diagnosis of a patient having a compatible skin lesion in an area where Lyme is endemic or recognized during the right time of year as being sufficient for a diagnosis of Lyme disease. And serologic testing is actually discouraged. However, reporting is based on a positive antibody test, so it becomes very obvious now why there's such massive underreporting and why the true number of cases is probably significantly more than those that are on that initial graph that I showed. All right, so with treatment at this early stage, the disease does not progress. However, in patients who don't get the appropriate therapy, they can go on to early disseminated disease, and that can be cardiac or neurologic. Cardiac disease accounts for only about 1% of infections. It's particularly most commonly manifested by conduction abnormalities like conduction blocks. There have been reports of sudden death associated with this, so it can be very serious, and there can be rapid progression from low-grade block to high-grade block, so these folks are typically managed in the hospital. Neuroborreliosis can take a number of different presentations. The most common is acute cranial nerve palsy, shown here. And unlike localized disease, there are a lot of things that can cause aseptic meningitis, can cause cranial neuropathy. And so this is a stage where antibodies should be present. And in contrast to early stage disease, serologic testing is essential for confirmation. My ophthalmology colleagues would say I'd be remiss not to mention that there are a number of ocular manifestations of Lyme disease. I have these shown here, and it's just really a reminder to think about Lyme if you're doing rotations where you're seeing patients with unexplained eye findings. All right, again, with treatment, there's no further progression. But in untreated patients, a third stage of Lyme disease occurs, which is late disseminated disease. And this is manifested by arthritis, which is the second most common clinical presentation, occurring in 29% of patients. Early on, before Lyme was recognized to be an infectious disease, patients, of course, weren't given antibiotics. And so we have some natural history studies from that period of time that suggest that 60% of untreated patients will develop Lyme arthritis. Because this can occur so late after infection, though, it can be really difficult to sort of correlate an earlier tick bite with the arthritis. And so things to look for would be an inflammatory arthritis involving one or just a few joints, and typically it would be migratory. The most common joints impacted are larger joints like the knees, but even the little joints, sternoclavicular and finger joints can be involved. I'd be remiss to talk about Lyme disease and not at least mention what has historically been called chronic Lyme disease. But this is a bit of an outmoded term, so just like this rotary phone, probably a bit out of date. And the preferred terminology now is post-treatment Lyme disease syndrome. Why is that? Chronic Lyme sort of implies that there may be active infection, and that's probably not the case. I'll talk about that on the next slide. So post-treatment Lyme disease syndrome is defined as symptoms occurring more than 6 months in a patient with meeting criteria for Lyme disease who's had appropriate treatment. It's fortunately fairly uncommon, occurring only in 5 to 10% of cases. And it's incredibly frustrating because these are real symptoms and these patients are suffering, but they're really not easily defined or diagnosed, their clinical symptoms. So this study looked at differences between patients with PTLDS and controls and found that patients with this post-Lyme disease syndrome were much more likely to have fatigue, joint pain, trouble focusing, brain fog, muscle pain, et cetera. And if this sounds familiar, this is a lot like what we see with post-COVID or long COVID. And so I think that as a society, we've become much more familiar with and comfortable with the fact that there can be long-term sequelae following resolution of an infectious disease. I think it's very encouraging to patients to know that this can improve over time. We don't know what causes it. There are a number of hypotheses. I have those listed here, but one of these, persistent infection, is really quite unlikely, and that's supported by the fact that there have now been 5 randomized trials looking at prolonged antibiotics, and none of them have shown benefit. I have the Please trial, which was one of the larger ones published in New England Journal, shown here. This one was actually stopped early because there was no positive effect. And I think the other point to emphasize is that long-term antibiotics do have consequences. So I won't go through these different cases, but this was an MMWR report put out by physicians at the CDC, where they had compiled 5 different patients who had been given prolonged IV antibiotics with no response, but all of whom had adverse reactions, some of whom died. So again, I think one has to be very careful about thinking that this might be an appropriate therapy. All right, well, it turns out Lyme disease is not the only disease spread by the Ixodes tick, and so I'm going to talk about 2.5 other diseases. Not surprisingly, because the same tick is the vector, we're seeing these occur in similar geographic regions. The first disease I'm going to talk about is babesiosis, and that's these dark green areas. So again, occurring in Lyme endemic regions. So Babesia is a protozoan parasite that lives inside red blood cells, and the clinical manifestations reflect that. The patients usually have findings that are related to hemolysis or anemia. All of these diseases can occur in isolation, or there can be co-infections. So patients, for instance, could have both Babesia and Lyme, and it's important to consider whether there is a second infection present. And because these parasites live in red blood cells, transmission can be through blood transfusion, organ transplant, or congenital spread. So most patients with Babesia actually are asymptomatic, and only about half will have symptoms. And in the majority of cases, these are quite mild. And I have these common ones here. It's basically a flu-like illness, very nonspecific. But in patients who have more severe disease, we'll see scleral icterus, shown there with the yellow eye, jaundice. Because of hemolysis, there can be sequestration into the spleen, so splenomegaly is present. And in rare cases, you can see spontaneous splenic rupture, shown here in the slide below. Smears can sometimes give the diagnosis. This shows 2 different findings. You can see these ring forms, which are actually very similar to malaria. And so getting that travel history may be really key in terms of differentiating these 2 entities. But the cross-like configuration, which is called a Maltese cross, is pathognomonic for babesiosis. This shows the rise in cases of babesia between 2011 and 2020. We don't have data that's more current. And I mentioned that only a subset of patients do develop symptomatic disease, and it's not random which patients are most at risk. Older individuals certainly make up a preponderance of severe babesia cases, but patients with asplenia are particularly prone to severe disease, those with immunocompromise, including HIV and other chronic health conditions. So I want to just mention a very, very effective intervention that was put into place in 2020. That's the year that the American Red Cross started screening blood donations in 14 states in the Northeast and North Midwest. They identified during this one-year period 355 infected donors that would have gone into the blood supply without this screening. And it turns out that history is a terrible way of identifying these patients. Only 39% had symptoms before they donated the blood. And this graphic just shows, again, once that screening went into effect, there were no further cases of transfusion-associated transmission. So a hugely successful and impactful intervention. If you ask me which of the diseases I'm talking about today I'd least like to have, it's Powassan virus. The reason is it can be transmitted by a tick within 15 minutes of attachment. So it's very hard to prevent this by doing tick searches or buddy searches. So it's a quickly transmitted infection, and it causes one of the most severe manifestations, which is encephalitis. It got a lot of press when Kay Hagan, who was a North Carolina senator, died from Powassan virus encephalitis. So Powassan is not a new infection, but it historically has occurred in areas outside of the United States. And there's an ecologic reason for this change. There's been mutations in the virus that allow it to become more commonly infecting Ixodes ticks, Ixodes scapularis ticks. And that's led to increasing cases in areas where Ixodes scapularis live, and that's highlighted by the map here with the dark blue colors. But because there's no commercial testing, we really don't have a great sense of how common this is. And this is sometimes called a tip of the iceberg type of infection, where we're only identifying the very sickest patients. So there's definitely a diagnostic bias. And that's reflected in the fact that of the 340 cases identified since this became reportable, almost all of them were hospitalized and mortality was 14%. Clinically, I already alluded to the fact that the most severe cases present with CNS infection. That can be meningitis or encephalitis. There can be abnormalities on imaging shown here. There's really nothing that distinguishes this from other forms of encephalitis other than possibly a history of antecedent tick bite. And I'll just mention that among survivors, 50% have long-term neurologic sequelae. So the disease I'm only mentioning in passing is anaplasmosis, and it's not because it's not important. It's actually the second most common tick-borne disease in the United States, with almost 7,000 cases in 2021. But the reason I'm giving this short shrift is it's almost identical to the disease I'm going to talk about next, which is ehrlichiosis. So I'm going to combine these two together. Ehrlichiosis is spread by a different tick, the Lone Star tick, so called because of that white spot on its back. It's pretty distinctive looking. And if you look at the map, it is endemic through the southeast and south central United States. So a little bit of a different distribution compared to the tick we've been talking about before. And again, anaplasmosis in areas we've already talked about, ehrlichiosis, more in my part of the world, in extending from Virginia, North Carolina, all the way to Oklahoma. And in case you doubt that this is endemic in Tennessee, that's my son's leg with a Amblyomma americanum tick on it. All right, until 2007, these two diseases were actually combined, and reporting was for both anaplasma and ehrlichiosis. But this slide shows since 2008, it's just Ehrlichia, about 2,000 cases a year. The blue bars are clinical findings with ehrlichiosis, the red with anaplasmosis. And again, both of these primarily cause a flu-like, very nonspecific presentation. There are some sort of red herrings. Sometimes if these present with cough, one might be thinking of community-acquired pneumonia. I've seen patients who've had cholecystectomy when they've come in with elevated liver tests and then ultimately were diagnosed with one of these tick-borne infections. And then about 20% of cases will have CNS manifestations. Rash occurs more commonly with Ehrlichia, but almost exclusively in kids, so I don't see it a whole lot in my practice. And just like babesia, you can sometimes get the diagnosis through smear, but it takes a dedicated microbiologist. A lot of fields need to be looked at. One of the Vanderbilt ID fellows, Kevin Kuriakis, and I did a study looking at outcomes of ehrlichiosis in patients at our facility. We identified 155 patients, and you can see it's a pretty severe disease. 88% were hospitalized, 28% required ICU care, and 4 died. The only predictor of adverse outcome that we were able to identify was delay in giving doxycycline, which is an oral antibiotic that's effective in this infection. And this is important when you look at mortality of Ehrlichia chafiensis. We see sort of this biphasic curve, highest rates of death in older adults, but also in young children. So let me delve into that just a little bit more. This is a study that looked at a number of different tick-borne rickettsial diseases, which include Ehrlichia, Rocky Mountain spotted fever, and anaplasmosis. And what these investigators found looking at insurance claims is only about 50% of folks who had a diagnosis of one of these tick-borne infections received doxycycline. And the population that was least likely to receive doxycycline was shown in the gray here, and that's pediatric patients that were less than 8 years of age. Only 24% of those patients got doxycycline. And so that sort of makes sense that the mortality is going to be highest in this group if there was a delay or absence of treatment. If you remember one thing from this talk, this is probably the most important slide. When I was in med school, we were always taught, it was dogma, that you don't give doxycycline to children who haven't erupted adult teeth because it could lead to discoloration, shown here. And that's old news because it turns out that that was with tetracycline and using doxycycline. There was a study that came out in 2000, I believe, 12, that suggested that really wasn't the case anymore. And so the CDC has done a very aggressive and very a widespread promotional campaign to try and re-educate providers of my era that doxycycline is safe in children and it should be given and it will save lives. And so again, please take that as the most important take-home message from this talk. All right, time is running low, so I will move on to the next tick-borne illness. This is yet another tick. This is the dog tick, the American dog tick, Dermacentor variabilis. And this is the vector for Rocky Mountain spotted fever. You can see the distribution of RMSF is historically east of the Mississippi. This is sort of an intermediate tick attachment, 6 hours for transmission to occur, and usually onset is within 14 days after tick bite. So this is something that's a little paradoxical. Every disease I've talked about up to now, there's been a rise in terms of the rate. And you can see that rise here up until about 2018, 2019. And then we see this sharp drop off. And that's not just because of COVID, that's because there was a change in case definition. It was recognized that a lot of these cases that were previously being called Rocky Mountain spotted fever were actually due to previous asymptomatic infection or a cross-reactive antibody from another rickettsial infection. So I'm not including this because there's been an increase in the number of cases. I'm including it because there's been a change in the epidemiology of cases. So if you look at the map, and you recall the map where I showed you where the dog tick was most commonly found, there's one outlier here, and that's in Arizona. In 2005, there was a report of a number of deaths in Arizona due to Rocky Mountain spotted fever, which was unusual because that wasn't believed to occur in that region. And certainly they don't have the same vector tick there. And so CDC did an investigation, and what they found was that there was a new vector that was competent to spread Rocky Mountain spotted fever, the brown dog tick. And this continues to be a tremendous problem in the Southwest United States. You can see cases continue to rise, deaths are still occurring. One study suggested that rates, particularly on Native American reservations, were 150 times the national average, and mortality in hospitalized patients was 17%. And again, this is still causing concerns. CDC put out a travel advisory in 2023 after 5 cases, most of whom are pediatric, returned from travel to Tecate, Mexico. All were hospitalized, 3 died. And a lot of this has to do with just a lack of provider education and delayed treatment. So Rocky Mountain spotted fever sometimes characterized by this classic triad. Almost all patients have fever, almost all patients have headache, and most patients have this very characteristic petechial skin eruption or rash. And so why am I calling this a diagnostic challenge? It should be fairly easy to recognize, right? Well, it turns out the timing is a little bit key in terms of when this rash occurs. The rash only initially presents at 2 to 4 days after onset of some of these more flu-like nonspecific symptoms. If treatment is deferred, this more petechial appearance occurs by day 7. And then one of the most dreaded complications, purpura fulminans, is by day 9. And I'm going to show you some pictures. So the early findings in Rocky Mountain spotted fever, and I use these two terms interchangeably. There's been sort of a change in nomenclature. So spotted fever group rickettsiosis is the other term. The earliest lesions are pretty subtle. There are these macules that usually occur on wrists and ankles. One clue may be the involvement of palms and soles, because very few dermatologic diseases involve those regions. So definitely think of Rocky Mountain spotted fever or syphilis when you see that. The face is typically spared, but again, this can be pretty subtle. It doesn't become subtle if patients are not treated. So the top 3 slides show the petechial disease seen with Rocky Mountain spotted fever. This bottom slide with the legs shows the purpura fulminans, and you can see there's a ton of desquamation. So these patients are at huge risk for secondary infections, and then you can see digital gangrene as well. And just like with Ehrlichia, treatment early is life-saving. So this slide shows patients who received treatment before on day 4 or before. Mortality was negligible, and survivors actually had almost complete recovery. But after day 5, there's a sharp drop-off with increased mortality and increased sequelae. And so again, this just recapitulates what I said with Ehrlichia, but I think it bears repeat. Mortality with Rocky Mountain spotted fever is highest in kids. Children under 10 years are only 6% of cases, but 22% of deaths. And maybe we should just put doxycycline in the water, because doxycycline should be given to any patient with suspected rickettsial infection. All right, so that was part 1 of my talk. The second reason that I would support tick-borne diseases exploding is a number of new or emerging novel tick-borne infections. And I'll preface this section with a quote by Socrates. All I know is that I do not know anything. And I say this because although we'll know the name of these diseases, there's very little information about how common they are, what the scope of infectious manifestations are. There's no commercial testing for them. So these are diseases that we really need, we have some significant knowledge gaps about. Okay, the first one I'll talk about is a viral illness called Heartland virus. This is so named because the first case was identified at Heartland Hospital in Missouri. There have been 60 cases that have been diagnosed to date. And the one way to recognize this is these are patients who present just like they have ehrlichiosis, but don't respond to doxycycline, the antibiotic treatment. And so that's sometimes the clue. There have been field studies that suggest that this is due to the same tick that causes Ehrlichia, the Lone Star tick, and the distribution on this map would support that as well. A second viral disease that was diagnosed 2 years later is bourbon virus. This again is named after the county it was initially discovered in. We know even less about bourbon than we do about Heartland, probably spread by the same tick, the Lone Star tick, but again, one that we have some significant gaps in knowledge on. Okay, and then I'm just going to go through a number of newly discovered tick-borne diseases. This is a rickettsial disease in California. There was a new discovery of a Ehrlichia species in Wisconsin and Minnesota. This is called Murus euclariensis. Just this year, in the last year, there was a new disease out of China called wetland virus. This is not a new disease. This is Rickettsia parkeri, but it's expanding its range into the Northeast, something that had never been identified before. And as I was looking for the citation for Westland virus, I saw a letter in the New England Journal from January of this year with yet another new virus from China. So a lot of new emerging tick-borne diseases, but if China seems really far away and these seem very distant, let me tell you about a case that's a lot closer to home. In fact, this was in my clinic. So this is a patient I saw about 3 or 4 years ago. It was a woman who had a first trimester miscarriage, and the pathologist who was looking at the placenta, John Newman and Hernan Correa, noticed a ton of inflammation on the pathologic specimen, and it looked very much like there was infection present. But when they looked for some of the usual suspects, they weren't able to find it. So I think that they should be lauded for sort of taking that extra step. They sent it off for molecular testing to University of Washington, and it came back with a bacteria called Candidatus midichloriae that is typically spread by ticks. There's never been a reported human case of it before. And the tick that spreads it is not known to be found in the United States. So this was a bit of a mystery. And when I saw this patient clinic, she was fortunately fully recovered, but she did recall a tick bite about 4 weeks before she had her miscarriage. And she actually had pictures on her phone that she shared with me and are shown here. So she had a little punctum at the site of attachment and then a red patch around it. And so further genetic testing showed that this organism is closely related to Rickettsia rickettsii, which causes Rocky Mountain spotted fever. It's, unknown. This may be a one-off. This may have been a random occurrence, or it could be that we're just seeing the first case in what will be a more commonly identified pathogen. But I think the take-home message here is how important molecular testing was in making the diagnosis for this patient and in a number of these newly discovered tick-borne diseases. And I won't go into detail, but we did collaborate with Mayo Clinic. We provided specimens from patients who had samples sent for Ehrlichia. And CDC did molecular diagnostic testing looking at shared bacterial epitopes. And really, this is the way the diagnosis is going to go in the future, I think. And it allows identification of previously unsuspected known pathogens and actually identified 2 new novel pathogens as well. So sort of this horizon, there's going to be, I think, an explosion of new tick-borne diseases discovered. Okay, I'm going to end the talk with the third topic, why I believe that tick-borne diseases are exploding, and this is referring to non-infectious tick-borne diseases. Up until now, everything I've talked about has been transmissible, but in this case, alpha-gal syndrome, we have a non-infectious disease spread by ticks. Alpha-gal refers to a carbohydrate, galactose alpha-1,3-galactose, which is present both in tick saliva and in red mead. And it's thought that following a tick bite, particularly Lone Star tick, there's stimulation of IgE. And when there's re-exposure to the carbohydrate antigen, IgG production can go quite high in some individuals. And this leads to an allergic reaction. But what's interesting is it's not an immediate hypersensitivity reaction. There's this delay of 2 to 8 hours, and that sometimes makes it difficult to correlate the timing of a meal containing meat with a reaction. Alpha-gal is not reportable, but a single lab does most of the testing. And so looking at where positive tests come from, you can see that the distribution is almost identical to that of ehrlichiosis, again, supporting that Lone Star tick is probably the most important vector for this non-infectious disease. I guess that's not a vector, it's a risk factor. But there may be other ticks that can also cause this as well. That's TBD. Some patients are only allergic to red meat in beef or buffalo, but in other more heavily impacted patients, you can see there's a whole bunch of different meat products to avoid. So this can be quite challenging from a dietary perspective for folks who have cross-reaction to a number of these different meat sources. Organ meats also can cause it, dairy and milk in a subset of patients. So again, very restrictive diet, lard, broth, gravy. But I think what's striking to me is how many medicinal products contain animal byproducts. So there are a number of considerations when seeing a patient with alpha-gal to avoid: gelatins, heart valves, heparin. So again, a pretty extensive list. The burden of disease, as I said, is unknown, but the CDC estimates there have been over 100,000 cases identified over this period from 2010 to 2022. There was an NIH study that looked at patients with idiopathic anaphylaxis. So this is a really highly selected population where they've been evaluated locally by an allergist. And when they looked at patients who resided in the Southeast United States, 9% were identified as having alpha-gal. And the authors postulated that this just wasn't recognized because of this delay in terms of onset of symptoms following ingestion. So this slide shows the symptoms of alpha-gal, and some of these are very classic for an allergic reaction: urticaria, which is hives or rash, angioedema, swelling of the throat, anaphylaxis. But some of these are a little bit unusual. GI manifestations can be quite predominant, respiratory diseases as well. Treatment is avoiding antigenic stimulation, whether it's with meat products or tick bites. And in some cases, if patients are able to successfully avoid further exposure, they can be cautiously reintroduced to meat products under the guidance of an allergy specialist. So I think this slide really sums up my talk. The ticks are winning. We're seeing increases in commonly identified tick-borne diseases. We're seeing an explosion of novel tick-borne diseases, and we're learning that ticks can cause non-infectious diseases as well. But my hope is that the next generation, some of whom may be here in this room, can reverse this, and that we'll find some novel diagnostics and therapeutics that will help us turn the tide here. So I'd like to finish by thanking many people, particularly the Watanakunakorn family for sponsoring this talk, to the faculty in biomedical sciences who was so gracious with my visit, and to Lindsay Loftus and Aaron Polson who have been wonderful hosts to me. So thank you again. I'd be happy to take questions.
It's a great talk. I mean, really entertaining and also instructive. You know, like the ticks are spreading out and they are winning. I think like to stop this kind of like, progression is very important. Do you have any like suggestions or envision regarding the national effort, how to stop this kind of tick spreading out?
That's a great question. So I think there are a couple different interventions, and a lot of them are things that we could talk to our patients about, I think, a little bit more effectively. I think during summer months, educating patients about the importance of prevention is key. Things that can be done is wearing light-colored clothing so you can identify ticks, doing buddy checks so you can look for ticks on different parts of the body that may not be so easy to see. But I think a really important intervention is using repellents like DEET containing, or there's some natural equivalents. So I think those are all really effective ways on the individual level. I think there's some community interventions that have been tried in the past. At one point, I know they have laid out ivermectin impregnated feed for deer, hoping that that would potentially decrease the burden of disease. And I don't know that that was terribly effective. I don't think it's being done anymore. But I think at this point, just knowledge, recognition, and maybe, again, counseling of patients before they're exposed.
Great talk. I learned a lot. I think our students feel the same way. I have questions about the post-Lyme disease syndrome. So what's the mechanism to develop those? Does it related to the bacteria itself, or like the delayed antibiotic treatment, or some like immune response?
So it's not known. I think most authorities would say that the latter supposition is most likely the delayed immune response. It does not appear to be due to delayed treatment. And the reason I say this is because it can occur with early stage disease, early disseminated, or late stage. So it doesn't seem to have a particular predilection for duration of infection. Again, it does seem to be very similar to post-COVID. And so, whether it's a dysregulated immune response, whether there may be components of the organism, some residual antigens that are sort of driving this immune response, not known, but that's sort of the current favored supposition.
Good, thank you.
Thank you.
I have two questions. I think one of the more difficult parts of tick-borne illnesses is the diagnosis part. So many of us are getting in-house testing for Lyme. now that we're seeing that prevalence increase, but previously it could take weeks to kind of get that information back. Have you seen any changes with the panels that are coming out with treatment is question one. And then the second one is, my dog gets a vaccine for Lyme. Is there anything out there for humans?
So those are both fantastic questions. And part of the reason I didn't include diagnostics is it's a bit of a morass. It's very complicated. So Lyme disease requires what's called a two-stage or two-step diagnostic testing. And historically, that has been an initial screening antibody called an ELISA or EIA, followed by a Western blot assay, with the Western blot being much more specific for Lyme, the ELISA being more sensitive. I don't work in the lab, but my understanding is that Western blot is fairly time intensive. There's some subjectivity on the part of reading them. And so about 4 or 5 years ago, the FDA approved an alternative two-stage approach, and that is to do 2 sequential ELISAs. And I think that's allowed in-house testing. And so we have in our hospital converted to that. I think a lot of hospitals have. So I think that's one big change that we're seeing, and we are getting more rapid results from that. Unlike many diseases, I'm a big fan of molecular testing, as I mentioned, but Lyme disease is one disease where molecular testing is clearly inferior to serologies. And so I think the things to keep in mind with Lyme diagnostics is, again, this delayed seroconversion. So you can certainly have Lyme with negative antibodies early on in the course of disease. But I think the two-stage EIA has improved our ability to make the diagnosis. The question about vaccine is a great one. There actually was a human vaccine on the market, and it was withdrawn because there were cases of arthritis related to the vaccine, not to infection. And again, it was sort of thought that it might have triggered an immune response in some folks, that there was molecular mimicry and it attacked joints. So this was taken off the market, although you're right, there are veterinary vaccines available. I think there's been a lot of interest in developing a vaccine. Again, if you think about the burden of disease, this would be something that would be very financially advantageous for drug companies, and that often drives, or drug vaccine companies, I guess, that often drives new innovations. But I am not aware of where we are with respect to that. I think I had seen that maybe in the Northeast they're doing some investigative trials, but TBD.
Hey, how are you? I apologize. Great talk. I had a question about the chronic Lyme disease. So that's a very controversial topic in medicine right now. So I actually wrote down a couple of questions I wanted to ask you. So the first one, you mentioned the randomized control trials. They gave these patients antibiotics and they didn't get better. So the first question is, how do you know that these patients actually had an active infection, right? Or if they just had post-treatment Lyme disease syndrome? Because as you know, the Western blot and the ELISA, both, once you make those antibodies, they'll stay persistently. The second question is, in animal models, if you look at them, they tend to have the Borrelia bacteria in immune privileged areas like the brain, heart, joints, right? But we can't test that, PCR or blood work. So how do you know for certainty what they are, like in the control groups, I guess? Like, how do you know they don't have fibromyalgia or yeah.
So I think you raise really good points. So I think these studies were designed very rigorously. So for instance, the PLEASE trial, they only took patients that had documented Lyme disease, that had been appropriately treated, and that were, I can't remember if it was 2 months or 6 months out from their diagnosis. So definitely they didn't want to muddy the water by including patients who had a Lyme mimicking disease. But these were all folks who had gotten appropriate treatment early on. And the controls were, when they looked at the baseline, they were very similar in terms of characteristics between the group that got prolonged antibiotics and the group that didn't. So the control group, was also a group that had Lyme disease and had this post-treatment Lyme disease syndrome. So I think that the fact that the studies were very well designed, and the fact that now there have been at least 5 of them, would argue against the possibility of prolonged antibiotics being beneficial.
Is that even with the non-human primate studies that show they remain?
So those were not, so those are just human studies that I'm talking about. There have been some studies that suggest, could there be a latent manifestation of Lyme disease? That's, again, a very controversial area. I don't know that we have the final answer on it. But I guess in my mind, I'd be surprised that if there was active bacteria, that these prolonged courses of effective antibiotics would not improve symptoms.
But we wouldn't know, right? Because they're in immune privileged areas that the blood test wouldn't pick up.
The blood test wouldn't pick up, but my hypothesis would be that antibiotics would still be effective in those.
Hi, Karen. Can I ask a question, please?
Sure.
Thank
Is this
you.
Eleanor?
This is Terry, and I
Okay.
appreciate your talk very much, especially the fact that it's exploding in Northeast Ohio. I know 4 people with Lyme disease, 2 are children. 1 is deaf in 1 ear, and 1 had to be on a educational disability, even though she was a stellar student before Lyme. And since then, I've gotten very involved in learning about Lyme, and there actually is still a lot of controversy. And a lot of it is, I think, a lack of education, both of the physicians and of the leaders in some of the organizations. I'm not sure if you're aware of Dr. Neil Spector's Lyme in the Era of Precision Medicine. He actually shows some of the neuroborreliosis organisms. They're spiral, they're in the brain. You're right, though, that we don't know if that's actually causing all the symptoms, but from the monkey brain trials done in the 1990s, there are lesions and plaques. And now dementia is actually found to be triggered by infections. There's a group called the Alzheimer's Pathobiome Initiative. The leader had Lyme, and one of the speakers who talks about military readiness, Nicole Malachowski, had Lyme disease. So it's really rocketed in evidence that I don't think most people are aware of. So I want to bring that to your attention. I would like to have National Brain Day declared, and let's get on the same page with this. And I wonder what your thoughts are on all of that, of how much is actually out there that we really don't know about. Thank you.
Thanks. I think you bring up some real gaps in our knowledge about Lyme disease. And I think, it's frustrating for patients and for providers. There are different philosophies, different approaches. I think it would be important for, there to be publications in peer-reviewed press sort of helping us as providers know what the right treatment is. And I think until we have those, there are going to be these continued gaps in knowledge. So I appreciate your perspective. I do think it's a problem. I know that the HHS convened a tick-borne diseases working group that included Lyme disease. I actually served on the rickettsial panel for that. And it included patient advocates, physicians more in conventional areas, and in some Lyme literate physicians as well. So I think that there was a diversity of membership on that. And I think that they would agree that there's still a lot we don't know.
Just a real quick follow-up. NIH budget is $49 billion a year, and Lyme has been controversial for 40 years. I would question, could they have a disease-specific target instead of the funding by individual researchers? Because I think that's part of the problem. I notice on 2 groups that are consortiums, the neuroimmune.org that's showing the mental illness from infections, and the allspi.org, that they often comment they have trouble getting funding because funding is by individual researchers. And I know CDC is trying to get more accurate information, yet in my family that had Lyme, the county health department doesn't check ticks. The hospital lab does not check ticks. And so I sent one away, and it had Lyme and Babesia within it. And it was only $35. So I'm hoping that maybe they could get some money into, let's find the answers. They've been controversy for way too long.
I think that's a fair point. I think, more money means more research and a greater understanding of these tick-borne diseases. And, I have no pull, but I would certainly be in favor of that. So I think that's an important consideration.
All right, it's time to, many of you have to be in class in 5 minutes, so we'll give you 5 minutes back. Sorry that you are there. So let's thank our speaker, and then we'll close up.